So are you guys really pumped and excited? Because this is the last week of pediatrics. Yay! You guys have made it. Now we're going to wrap up the week and we're going to talk about some endocrine dysfunction. So the endocrine system consists of three basic components as they are listed on your slide. Where do the hormones come from? You have your hypothalamic pituitary axis, and it produces a lot of releasing and inhibiting hormones. Some of these hormones are going to regulate the things that are listed for you on your slide, your thyroid, adrenals, and the male and female reproductive glands. Your hypothalamus also is the maker of the hormones, and your pituitary gland stimulates or inhibits the release of those hormones. It also contains its own hormones too. So if you think of your hypothalamus as the baker in the back of like a bakery who makes the sweets, who makes the cinnamon rolls, or the hormones, if you will. And your pituitary gland is like your bakery manager who decides he's out front dealing with the customers and he decides how much and what product you need to put in the store for that day. Yeah? This is really a good analogy. I'm going to build on it some more. Hormones from your hypothalamic pituitary axis regulate growth. You also have your parathyroid glands, and then you have your cells that are responsible for the secretion of insulin. So I like charts and tables because sometimes it's just nice to organize information. So these are just listed out for you what hormones come out of what gland and what they do. The next two slides just go over that. So the endocrine system communicates via negative feedback loops. What happens is the endocrine gland gets a message from the target cell that they have adequate amount of hormone and that they don't need any more. Thus, the continued release of that hormone stops. Again, so it's kind of like the bakery manager calls back, we'll just call him bakery manager, calls back to the baker, we'll call him Bruno, and says, stop making chocolate chip bagels. We have 12 dozen. We're good. We don't need any more. So the baker, Bruno, he stops making them and sending them out front to the store. That's kind of cool. Instead, the bakery manager calls back and says, but we are running low on cherry Danish, so why don't you start making some of that? The endocrine system, okay, so that's negative feedback. Differentiation of the sexes occurs during fetal development, and that is sponsored. I'm going to call it sponsored by the endocrine system, but it happens because of the endocrine system. Endocrine system is also responsible for the growth and development of children through adolescence. Did you guys know that puberty lasts 4.5 years? Oh, yay. I just say that because I have one kid who is in puberty and I have two more that are probably like rapidly approaching, like on the outer cusp, and oh gosh, 4.5 years. My house. I don't know if I'm strong enough to do it. I need some very strong vitamins. Ages when it starts are listed for you on your slide. I think it'd be pretty cool if we all had a t-shirt that says you're male because I said so, and you're growing up well because I said so. And then on the back, it should say sponsored by your endocrine system because that's what your endocrine system does. In general, disorders of pituitary function affect growth and they affect fluid balance. So the things that are going to affect growth are listed for you. And then of course the things that affect fluid balance are SIADH, or syndrome of inappropriate antidiuretic hormone, and diabetes insipidus. All right, hypopituitarism is a big one because it's basically a deficient secretion of pituitary hormones. It is diagnosed in males. It's diagnosed earlier in males than females because they are often referred for short stature. The consequences, it depends on the degree of the dysfunction. Gonadotropin deficiency is the absence or regression of secondary sex characteristics. Growth hormone deficiency is going to equal slowed somatic growth. TSH deficiency is going to result in hypothyroidism, and corticotropin deficiency is going to result in adrenal hypofunction. Now, the cause can be from tumors in the pituitary gland, or it can just result from growth failure. Other potential causes for hypopituitarism include an infarction of the anterior pituitary gland due to something like sickle cell, CNS infections, tumors, cranial irradiation, brain trauma, chemo, psychosocial deprivation. We'll talk about that in a little bit. Other potential causes can be just familial short stature, hypothyroidism, Turner syndrome, constitutional growth delay, chronic renal failure, Cushing syndrome, Down syndrome, inborn errors of metabolism, as well as severe cardiac, pulmonary, immunologic, or GI disease. Now, growth failure, when it occurs without the presence of hypothyroidism, okay, without hypothyroidism, just growth failure, without also systemic disease or malnutrition, because we have to rule those things out, then you really need to consider abnormal growth hormone, insulin-like growth factor. That's what it's called, growth hormone, insulin-like growth factor. Now, not all children who are short have a growth hormone deficiency. Sometimes it's just a constitutional growth delay in which the delayed growth beginning as a toddler, and then they can have skeletal and sexual maturity that is behind that of most children of that age. Typically, these children will go ahead and reach their full adult height. There may be a family history of growth patterns like this. But again, constitutional growth delay, these are your late bloomers. These kids grow normally during the first year of life, and then they slow down. They appear younger than their actual age, and then of course even dentition, sexual development, and puberty may all be delayed. And these kids, it may take them a long time to reach their full adult height. They may keep growing into their 30s or maybe even 40s. Okay, so to diagnose a growth hormone deficiency, first they're going to take a very detailed family history. They want to know everything. They want to know height of everybody else in the family, on both sides. They want to know, all kinds of information about the pregnancy. They want to know everything. There, of course, will do a physical examination. They will do a psychosocial evaluation as well. We'll talk about that because, well, I'll just go ahead and jump to that. There is a condition called psychosocial dwarfism, in which severe emotional deprivation can cause suppression of the pituitary hormone production, which results in transient growth hormone deficiency. It is reversible though. So you think about the kids who are just being totally neglected and are not, their caregivers, whoever, if it's parents, foster, whoever it is, they're not having their psychosocial needs met. They may not grow very well because they're not being loved on enough. But it is reversible. As far as radiology goes, they'll do a skeletal survey. Sometimes they'll do a bone age test too. I didn't put that in there, but they will. But they will do a skeletal survey in children who are less than 3 and determine the hand, wrist for bone age. Or they can just do a plain hand x-ray, and that's called a bone age survey. You should know that the level of growth hormone in children varies. So they do a lot of screening tests first with levels of IGF-1, and if that is abnormal, then they will stimulate the release of growth hormone via medication and then draw blood. So your job as a nurse, as far as the therapeutic management of growth hormone deficiency, is teaching. Also, it's going to be identifying and assisting with the diagnosis, so helping parents find the resources that they need, help them, teach them all about the, growth hormone replacement. Make sure you teach them to administer at bedtime. Again, provide child and family support, maybe assist with some emotional adjustment for the child, preparation for testing, so, preparing the parents and the child for the growth deficiency testing, and then, of course, the med administration, and then provide increased attention to the child during testing. So they have to be your focus because somebody else is going to be doing the test. All right, so now let's shift gears and talk about pituitary hyperfunction, since we just talked about hypofunction. If you have excessive growth hormone before your epiphyseal plates close, that's going to make you very tall. really tall, like up to 8 feet tall. It's important to know that the weight and height do increase proportionally with this. If the excess growth hormone occurs after the epiphyseal plates close, you get a condition called acromegaly. But then instead of the bones growing vertically and in proportion, the bones grow transverse. The head grows as well as the lips, nose, tongue, jaw, paranasal, and mastoid sinuses. Teeth can become separated due to the enlarged jaw. There's a disproportion to the face, to the cerebral division of the skull. These children are going to have increased facial hair, thickened, deeply creased skin, and an increased incidence of hyperglycemia and diabetes. So this is going to be diagnosed by lab studies. Again, we'll see increased levels of growth hormone. And radiology studies may show a tumor in the brain, normal bone age, but enlargement of the bones and joint changes. The lab work may also show excess in other hormones too, such as thyroid, cortisol, and sex hormones. So the video clip that's on here is just really silly because obviously the pituitary hyperfunction, that's what Andre the Giant suffered from. I just put a clip in there so you can kind of see wow, he is significantly bigger than the other dude. And the video clip is just silly. It's a clip from Princess Bride. And it's in the movie right after Wesley defeats the giant and he knocks the giant out and he tells the giant to dream of large women. And it's just for comedy. It has absolutely no bearing in this course. All right, so precocious puberty is the appearance of secondary sex characteristics too soon. Kids are starting to hit puberty before they are like scheduled and really supposed to. Causes are listed for you. See box 46-4 in your text. It's going to be diagnosed possibly with an advanced bone age. So they may see some premature skeletal maturity. Kids may seem unusually tall for their age. It can also cause them to have a lot of mood swings and emotional lability, which is what you would see in puberty. One of the reasons that this happens is possibly because of a tumor. It can also occur after encephalitis, meningitis, an abscess, trauma, or neoplasms. Now, the good news is in 50% of cases, precocious puberty, the development stops all on its own. But if it doesn't, then it's going to be treated with Lupron, which is a gonadotropin-releasing hormone analog. It's going to slow the prepubertal growth rate down to normal rates. Treatment is going to be discontinued when the child reaches the age when normal puberty changes are expected to resume. In both cases, though, children are likely to have body image disturbance issues. And I just thought that was cute, having a little baby with the facial hair growing on. So diabetes insipidus can be from antidiuretic hormone deficiency, or ADH, or it can be idiopathic in origin. What does ADH actually do? Well, it's secreted by your posterior pituitary gland, and it tells your kidneys to concentrate the pee because water reabsorption is needed. In diabetes insipidus, there's not enough ADH. So the renal tubules don't reabsorb any water, which leads to polyuria, which results in dehydration. This often occurs it can occur due to a lack of ADH or when the renal tubules don't respond to the ADH. Brain tumors are a common cause of this. Other causes would be brain trauma, CNS infection, and neurosurgery. So what happens clinically? You pee a lot. I mean a lot, and it's all diluted urine. Cardinal signs are polyuria and polydipsia. Infants, they may have some irritability relieved with feedings of water, but not milk, and dehydration will often occur. It's diagnosed by reducing fluid intake with little or no effect on urine output. So you take away fluids and put them on a fluid restriction, and they keep peeing out like vast quantities. So what do we do for the treatment? Well, one of the biggest things is when you start talking about diabetes, you really need to make sure parents understand that this is different than diabetes mellitus or mellitus, however people want to say it. Sometimes it's fun to say that sugar diabetes. It is different than the sugar diabetes. Kids can do a daily hormone replacement, or you can do, which is vasopressin. They also have it available as a nasal spray, or they can do like an IV injection. It can be given sub-Q or IM as well. But treatment is going to be required for life because if you don't, you're going to dehydrate yourself. Now, the injectable form lasts 48 to 72 hours. It has to be resuspended in oil by putting it in warm water for 10 to 15 minutes and then vigorously shaking it before drawing it up. You must see small brown particles in it before drawing it up. I don't know if that'll be on boards, but you should know that there's something special you have to do if you're going to inject vasopressin. Personally, I think a nasal spray sounds a whole heck of a lot easier, especially for a kid. Alright, so now let's talk about the opposite, SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. Basically, you have too much antidiuretic hormone in your blood. So what happens, you have a failure of your normal feedback loop from the hypothalamus, pit gland, and your kidney, and it results in excessive secretion of antidiuretic hormone, which leads to water reabsorption, despite the low serum osmolality. Result, you have an increased intravascular volume and decreased urine output. It also causes suppression of the renin-angiotensin system. End result, water intoxication, hyponatremia, and cellular edema. Alright, so let's talk a little bit about thyroid. Thyroid hormone regulates your basal metabolic rate. The function of T4 and T3 are similar, and so they are usually just lumped together as generic thyroid hormone for practical purposes. What do you have to build thyroid hormones? You have to have iodine and tyrosine. The thyroid is the only endocrine gland with a storage mechanism for excess hormone. T3 and T4 are bound to a carrier protein, and they stay that way until they are needed, at which time they unbind. Now, you also have calcitonin. Calcitonin helps maintain your blood calcium levels by decreasing your calcium concentration. You also have parathyroid hormone. Now, parathyroid hormone is pretty sneaky. Picture the little black and white hamburglar from McDonald's swimming around in your blood with a little sword, running around, tapping your bones with his tiny little sword. Tap, tap, ha ha, ha ha, ha ha, and releasing calcium from your bones. Ha ha, see? You're picturing it, aren't you? And you're laughing hysterically. Calcitonin inhibits skeletal demineralization and promotes calcium deposits in your bone. So calcitonin basically shoos your parathyroid hamburglar away. It's kind of like having a house alarm or bone alarm, I guess. But it tells your parathyroid hormone, hey, you can't have my calcium. Move along, move along. That's what calcitonin does. Pretty sweet, huh? So hypothyroidism can either be congenital or it can be acquired, and it is more common in girls than boys, which is rare because most of the time in pediatrics things are more common in boys than girls, but not in this case. If it's congenital, it's caused by a genetic mutation, either spontaneous or inherited, or from hypoplasia or aplasia of the thyroid, failure of the CNS thyroid feedback loop to develop, or iodine deficiency. I'm going to tell you, dietary or iodide deficiency that rarely occurs in the US because we all iodize our salt. We don't have a choice. Like, it comes from the salt factory already pre-iodized. Because remember how I just told you on the last slide that we need iodine and tyrosine to build thyroid hormone? Yeah, that's why nobody really has hypothyroidism due to like dietary reasons anymore, because we all eat a lot of salt. All right. It can also be acquired or idiopathic, or you can have autoimmune thyroiditis. You can have late onset thyroid dysfunction, isolated TSH deficiency due to hypothalamic or pituitary dysfunction, or you can have exposure to drugs that interfere with thyroid hormone production, such as lithium. Now, something called lymphocytic thyroiditis. I told you to see box 46-6. That's what your typical Hashimoto's disease causes, an enlarged thyroid. Peak incidence is around adolescence. Symptoms? Check your box. Now, you can get a goiter. It can occur with hyper or hypothyroidism, and it can be congenital or acquired. Treatment for a goiter is going to include possible radiation, surgery. They can do a partial or complete thyroidectomy, and subsequent thyroid replacement drugs if they take part of it out. So all newborns are going to be screened for hypothyroidism before they leave the hospital. It's part of that Missouri newborn screening. Hypothyroidism is one of them. Remember, if you have hypothyroidism, you're going to have a high TSH, right? Because your thyroid is not functioning. So thyroid stimulating hormone is going to be kicked into overdrive because it's like throwing, baseballs at, somebody who's asleep saying, wake up, wake up, wake up. But you're going to have a low T4 level. If you have hyperthyroidism, then you're going to have a low TSH because the feedback loops are saying, no one's going to be throwing baseballs. You're trying to like tiptoe around and let this person sleep because you do not need any more activity from that thyroid. So some of your symptoms, I put the symptoms for early infancy on there. The large protruding tongue, that's a big one. That's like a good boards test question right there. Coarse hair, lethargy, sleepiness. Kids who have hypothyroidism, those are like usually like really good babies. The babies who the moms come in and they say, this baby never cries, ever. And you go, really? Because that's abnormal. Those are the babies you worry about. And you go, maybe we should draw some labs. Other things you're looking for in kids, the myxedematous skin changes, dry skin, sparse hair or like coarse hair, puffiness around the eyes, and then I put on there CBOX 46.5 because it's just easier than typing it all out, and that way you guys need to look in your book at some of this stuff anyway. Hypothyroidism is going to be treated with Synthroid. Again, don't forget, babies are going to have labs drawn, on a pretty frequent basis, and as the child grows, you have to increase your dose of medicine too. Synthroid, of course, is given once a day. It's a pill. You crush it up and you mix it in with a little bit of breast milk or formula and give it to the baby. We're not going to give it into an entire bottle because that will inevitably be the one time the baby does not take the full bottle. So you put in a small amount, like 5, 10 mLs tops, because generally a baby will take at least 5 to 10 mLs. Signs of overdose, you need to teach parents that. Signs of underdose, you need to teach parents that. You should also know that babies born with a goiter may need surgery. By suppressing TSH activity, the thyroid will eventually go back down to normal size. All right, hyperthyroidism is also known as Graves' disease. It is caused by an autoimmune response to the TSH receptors.